Let us start with chapter 62 of your Apurba Sastry Essentials of Microbiology, which is about bacterial atypical pneumonia, which is the interstitial pneumonia. In this chapter, we will be previewing Mycoplasma pneumonia, Chlamydia pneumonia, and Legionellosis, and some other bacterial atypical pneumonia as well. Introduction. Atypical or interstitial pneumonia refers to infection occurring in the interstitial spaces of lungs. Cough is characteristically non-productive. The common agents include respiratory virus such as influenza virus, coronavirus, respiratory syncytial virus, and others such as Epstein-Barr virus and adenovirus. Bacterial agents causing atypical pneumonia are Mycoplasma pneumonia, also called as walking pneumonia, as symptoms tend to be milder than other agents causing pneumonia. Chlamydia, Chlamydophila pneumoniae, Chlamydophila pistachyi, Chlamydia trachomatis, serotypes D to K. Legionella species cause Legionnaire's disease. Less common bacterial agents like Coxiella burnetii, Q fever, Francisella tularis, which causes pulmonary tularemia, and Orientia suzugamushi, which causes strep typhus, can also present with interstitial pneumonia. It is important to differentiate atypical pneumonia from typical lobar pneumonia, as the antibiotics used for their treatment are different. However, there is considerable overlap. Many typical agents can be atypical and in the presentation and vice versa. This chapter will mainly focus on the bacterial agents causing atypical pneumonia. Mycoplasma pneumonia. Mycoplasma pneumonia is one of the most common bacterial agent causing atypical pneumonia. The disease is described as primary atypical pneumonia. General properties. Mycoplasmas are the smallest microbes capable of free living in the environment and self-replicating on artificial culture media. They have the following characteristic as mentioned below. They resemble the virus in certain properties such as size. They are small, 150 to 350 nanometers in size. They are filtrable by bacterial filters. They differ from virus as they are free living in the environment. They can grow on artificial cell-free culture media. They lack a rigid cell wall, which is replaced by a triple layered cell membrane containing sterol. Therefore, they are completely resistant to antibiotics acting on the cell wall, such as beta-lactams. Pleomorphic, they are highly pleomorphic, exist in coccoid, bacillary, or filamentous, or even helical forms, as in spiroplasm. They are poorly gram-negative, better stained by Giemsa stain. They reproduce by binary fission and budding. They are non-sporing and non-flagellated, usually non-motile. However, gliding motility is described in some species, which is due to the specialized tip structures. Contaminants of the cell cultures. Mycoplasma are the common contaminants of continuous cell lines, thus interfere with the growth of viruses in the cell cultures. L form, as mycoplasma lacks cell wall permanently, it has been suggested that the mycoplasmas may represent stable L forms of bacteria, but genetic, antigenic, and biochemical properties do not support this hypothesis. History. The name mycoplasma derived from myco, meaning fungus-like, forming branches, filaments, and plasma, denoting the plasticity of the shape. They were previously called as pleuropneumonia-like organisms, PPLO, and Eaton's agent, after the Monro Eaton who first isolated them. Classification. Family Mycoplasmataceae comprises of two genera, Mycoplasma and Ureaplasma. The pathogenic species infecting humans are Mycoplasma pneumoniae, which causes atypical pneumonia, which is discussed. Other species causing urogenital infections are such as Mycoplasma hominis, Mycoplasma genitalium, Ureaplasma urelyticum, and Ureaplasma parvum. Pathogenesis. Attachment of M. pneumoniae to the respiratory mucosa is the most important step in the pathogenesis, which is mediated by its membrane-bound adhesin protein. Example, cytidine P1 protein, following which it reduces injury to host respiratory tissue. Epidemiology. Mycoplasma pneumonia infection occurs worldwide. Transmission. M. pneumoniae is transmitted by respiratory droplets. Facilitating factors. Transmission is favored by close contacts, as in families, military bases, boarding schools, and summer camps. Infections tend to be endemic with periodic epidemics every 4 to 7 years. Incubation period is about 2 to 4 weeks. Clinical manifestation. M. pneumoniae produces various infections which are as follows. Upper respiratory tract infection, URTI. URTI manifests as pharyngitis, tracheobronchitis, or rarely as otitis media. It is acute in onset and 20 times more common than pneumonia. Pneumonia. M. pneumonia causes atypical community-acquired interstitial pneumonia, similar to pneumonia caused by other agents such as Chlamydophila pneumoniae, Legionella pneumophila, and the viral pneumonia. This is also referred to as eaten agent pneumonia or primary atypical pneumonia or walking pneumonia, as symptoms tend to be milder than pneumonia due to other agents. Pneumonia develops in 3 to 13% of the infected individuals. Its onset is usually gradual. It is characterized by wheeze or rales, dry cough, and peribronchial pneumonia with thickened bronchial markings and streaks of interstitial infiltration on chest X-ray. Pneumonia usually is mild and self-limited but can progress into severe disease with acute respiratory distress syndrome ARDS. Extrapulmonary manifestations are rare, occur either as a result of active mycoplasma infection, example septic arthritis, or due to post-infections autoimmune phenomena, example Guillain-Barré syndrome. Various manifestations include neurologic encephalitis, Guillain-Barré syndrome, and aseptic meningitis. Dermatologic are skin rashes, including erythema multiforme major, Steven-Johnson syndrome, cardiac myocarditis, pericarditis, rheumatologic reactive arthritis, hematologic anemia, and hypercoagulopathy. Lab diagnosis of Mycoplasma pneumonia. Specimen throat swab, nasopharyngeal aspirates, bronchial brushing, BAL, and lung biopsies. Culture solid medium containing PPLO agar produces fried egg appearance colonies. Liquid medium containing PPLO broth produces turbidity and a color change. Identification accurate species identification from colonies is made by biochemical test or by automated identification systems such as Marley-Dorf. Antigenic detection by direct immunofluorescence, antigenic capture ELISA. Antibody detection in the serum, specific indirect immunofluorescence, latex agglutination assays, and ELISA using protein P1 antigens, non-specific cold agglutination test, and Streptococcus MG test. Molecular method detect 16S rRNA and P1 adhesin gene. Lab diagnosis. Specimen collection and report. Ideal specimens are throat swabs, nasopharyngeal aspirates, bronchial brushing, bronchoalveolar lavages (BAL), and lung biopsies. Specimens must be placed immediately into the following transport media to avoid drying. Standard mycoplasma fluid medium containing fetal bovine serum, gelatin, and penicillin. Viral transport medium added with ampicillin and cefotaxime. Transportation should be immediate. If delay is expected, then specimen should be stored at 4 degrees Celsius for 48 hours and beyond that at minus 70 degrees Celsius. Culture. Specimens are inoculated in culture media such as PPLO agar or PPLO broth and incubated at 37 degrees Celsius for 5 to 7 days or sometimes even up to 1 to 3 weeks. In liquid medium containing PPLO broth, M. pneumoniae growth is detected by turbidity and a color change. In solid medium containing PPLO agar, the colonies appear very small, 200 to 500 micrometer sized, embedded on agar surface described as fried egg appearance colonies. The colonies can be examined by hand lens or use of special stains such as Dini staining, a non-specific stain that imparts color to mycoplasma colonies on agar. In this figure, we can see the mycoplasma colonies which have a typical fried egg appearance. Culture of respiratory specimen has a sensitivity of less than 60 and specificity of 100%. Identification accurate species identification from colonies is made either by conventional biochemical test or by automated identification systems such as Marley-Dorf. Antigen detection, direct immunofluorescence test detects mycoplasma antigens directly in the clinical specimens. Capture ELISA assay is available using monoclonal antibodies against P1 adhesion antigen. Antibody detection in the serum, specific antibody detection test, antibodies specific to M. pneumoniae protein and glycolipid antigens can be detected after about 1 week of illness and peak at 3 to 6 weeks and then decline gradually. Serological assays have a sensitivity and specificity of 55 to 100%. IgM antibodies are frequently elevated in children with acute infection, whereas in adults, IgA antibody detection remains the method of choice for the diagnosis of acute infection. Various specific antibody detection tests are as follows: immunofluorescence assays, latex agglutination assays, ELISA using protein P1 antigens, non-specific antibody detection test, heterophile agglutination test such as cold agglutination test and Streptococcus MG test were in use in the past, now obsolete, so they are neither specific nor sensitive, positive only in 30 to 50% of the cases. The molecular methods: PCR targeting M. pneumoniae specific 16S rRNA gene and B1 adhesin gene are available. PCR has a sensitivity of 65 to 90% and specificity of 90 to 100%. Multiplex PCR has been developed detecting common agents of atypical pneumonia like M. pneumoniae, Chlamydophila pneumoniae, and Legionella pneumophila. Real-time PCR is useful for quantitative detection of the M. pneumoniae. Bi-5 film array is an automated multiplex PCR in the respiratory panel can simultaneously detect 22 pathogens including M. pneumoniae. Mycoplasma pneumonia treatment macrolides are the drug of choice. Oral azithromycin 500 mg on day 1, then 250 mg on day 2 to 5. Alternative drugs are as follows: doxycycline and respiratory fluoroquinolones such as levofloxacin, moxifloxacin, and gemifloxacin, not ciprofloxacin. Chlamydia pneumonia. There are three chlamydia species: C. pneumoniae, C. bistaki, and C. trichomatis. All are capable of causing atypical interstitial pneumonia. Pistacosis or Chlamydophila pistaki. C. pistaki is a pathogen of parrots and other pistachine birds causing pistacosis. Reservoirs: pet birds, parrots, parakeets, macaws, and cocktails, and poultry like turkeys and ducks act as natural reservoir of infection and are involved in transmission of infection to humans. Mode of transmission: C. pistaki can be transmitted to humans by inhalation of aerosols from avian nasal discharges and from infectious avian fecal or feather dust. Clinical manifestation: incubation period ranges from 5 to 19 days. It can present as respiratory manifestation. Most common form varies from a mild influenza-like syndrome to an interstitial pneumonia, and secondly, rarely septicemia and typhoid-like syndrome. Treatment: tetracycline is the drug of choice, given 250 mg 4 times a day for at least 3 weeks to avoid relapse. Erythromycin 500 mg 4 times a day per oral is given alternatively. Chlamydophila pneumoniae. C. pneumonia is an exclusively human pathogen. It is transmitted from person to person by inhalational route. It causes various manifestations. Atypical pneumonia. C. pneumonia is a common cause of atypical interstitial pneumonia, accounting for 10% of the cases of community acquired pneumonia. Upper respiratory tract involvement is frequent, such as in pharyngitis and sinusitis. Atherosclerosis: there is a strong evidence of association between C. pneumoniae and atherosclerosis of coronary and other arteries. Asthma and COPD: C. pneumoniae may cause exacerbations of bronchial asthma and COPD, chronic obstructive pulmonary disease. Treatment: tetracycline or erythromycin 500 mg 4 times a day is recommended for 10 to 14 days. Chlamydia trachomatis infant pneumonia. C. trachomatis serotypes D to K can cause infant pneumonia, which is an interstitial pneumonia that develops within 3 weeks from to 3 months of birth. Infection spreads from conjunctiva to pharynx via the nasolacrimal duct. Infection via the eustachian tube may cause otitis media. Treatment: erythromycin is given orally at a dosage of 50 mg per kg per day in 4 divided doses for 2 weeks. C. trachomatis mainly causes urethritis and ocular infection discussed. General lab diagnosis and chlamydial infection will be discussed in later chapters. Now coming on to legionellosis. Legionella are fastidious pleomorphic gram-negative short rods associated with interstitial pneumonia known as Legionnaire's disease. History: Legionella was first recognized in 1976 when an outbreak of pneumonia took place at Philadelphia Hotel during an American Legion convention. Classification: out of several species infecting man, L. pneumophila is the most important species, associated with 80 to 90% of human infection. It consists of 15 serogroups. Majority of cases are associated with serogroup 1, followed by 4 and 6. Other species are rarely associated with human infections, particularly in the immunocompromised state, such as L. McDagdy, Pittsburgh pneumonia agents, and L. Wadsworthy and L. Longbecke. Epidemiology: reservoir Legionella inhabits on the aquatic bodies, which could be either natural water sources such as river, stream, or even inside amoeba. Artificial aquatic sources such as air conditioner, water cooler, shower head, large plumbing system, and decorative fountains. L. Longbecke has been isolated from natural soil and commercial potting soil. There is no animal reservoir, there is no carrier stage. Now, the transmission: multiple routes have been proposed. Aspiration predominant mode occurs via oropharyngeal colonization or directly via drinking of contaminated water. Aerosols from contaminated air conditioners, nebulizers, and humidifiers. Direct instillation into the lungs during respiratory tract manipulations. There is no man-to-man transmission known. Predisposing factors for Legionella infection include smoking, alcoholism, or chronic lung disease like chronic obstructive pulmonary disease or emphysema, impair mucociliary clearance, advanced age, immunosuppression, transplantation, HIV infection, steroid therapy, prior hospitalization, and patients with nasogastric tubes or those undergoing surgery with general anesthesia promotes aspiration. Now, pathogenesis following entry Legionella reach the lungs where they are engulfed by alveolar macrophages by a mechanism called as coiling phagocytosis. They invade and grow within the alveolar macrophages by inhibiting the phagosome-lysosome fusion. Being intracellular organism, cellular immunity is responsible for the recovery. Clinical manifestation Pontac fever. It is an acute flu like illness characterized by malaise, fever, and headache. Incubation period is about 24 to 48 hours. It is self limiting, never develops into pneumonia. Legionnaires disease pneumonia. It is an interstitial atypical pneumonia with an incubation period of 2 to 10 days. It is characterized by non productive cough with or without blood tinged dyspnea, chest pain, high fever, and diarrhea. Chest X-ray shows pulmonary infiltrates. Legionella is among the leading cause of pneumonia both in the community and hospital setting. Extrapulmonary legionellosis usually results from blood-borne dissemination from the lung. The most common extrapulmonary site is the heart, myocarditis, pericarditis, and prosthetic valve endocarditis. Other manifestations include sinusitis, peritonitis, pyelonephritis, skin and soft tissue infection. Now, the lab diagnostic useful specimen for Legionnaires disease includes sputum, bronchial lavage, fluid bronchial wash, and pleural fluid. In this figure, we can see the Legionella species in gram staining and growth on BCYE agar. Now coming on to the direct microscopy, gram staining reveals numerous neutrophils but no organisms as Legionella are poorly stained, often missed or sometimes appear as faint pleomorphic gram-negative rods or cocobacilli. Silver impregnation and Giemsa stains can be used. Direct immunofluorescence test using monoclonal or polyclonal sera is more specific but sensitivity is poor than culture. It is more useful in advanced stage of the disease. Acid fast staining L. McDaddy is a weakly acid fast culture. Culture is highly sensitive 80 to 90% and specific 100% and provides definite diagnosis. Buffered charcoal yeast extract BCYE agar. Legionella are highly fastidious and grow on complex media such as BCYE agar after 3 to 5 days of incubation at 37 degrees Celsius in 5% CO2. Species identification of Legionella from colonies is made either by conventional biochemical test or by automated infection identification system such as Marlitov. Antibody detection primarily serology is used for epidemiologic purpose, seroprevalence estimation. Indirect immunofluorescent antibody test and enzyme immunoassays are available. Antibodies usually appear late after 12 weeks. A single titer of 1 is to 256 gives presumptive evidence of Legionnaires disease. Cross reactivity has been observed with other Legionella species. Urinary antigen test. Enzyme immunoassays are available to detect L. pneumophila serogroup 1 specific soluble antigen in urine. Advantages include as follows. It is rapid, cheaper and easy to perform. It is highly sensitive 70 to 90% and specific 95 to 100%. Antigen in urine is detectable shortly after the onset of symptoms and disappears over 10 months. The test is not affected by prior antibiotic administration. Molecular method biofilm array automated multiplex PCR is available. Its respiratory panel can simultaneously detect 22 pathogens including L. pneumophila. Treatment of Legionnaires disease. Macrolide, especially azithromycin and the respiratory quinolones like levofloxacin are now the antibiotics of choice. Water surveillance for Legionella. Indication routine water surveillance for Legionella is not recommended but should be performed annually or more often for certain high-risk settings such as transplant units. Procedure large volume of water 1 to 10 liter are collected and subjected to membrane filtration followed by culture on BCYE media. Other bacterial atypical pneumonia, Coxiella burnetii causes Q fever transmitted by inhalational mode. Interstitial pneumonia is a common presentation in Q fever. Rickettsial infection intestinal pneumonia may be a rare complication seen in various rickettsial infections and such as strep typhus, epidemic typhus, endemic typhus and Rocky Mountain spotted fever. It occurs in severe cases due to vascular injury. Francisella tularensis is the causative agent of tularemia, primarily a zoonotic disease. Pulmonary tularemia can result from the aerosol inhalation in lab workers or can spread to the lungs following bacteremia. Patients present with atypical pneumonia. And this short notes on mycoplasma pneumonia, pistacosis, and liganes disease can be asked, which we can answer. The agent of primary atypical pneumonia is its Mycoplasma pneumoniae, and which of the following is associated with pathogens of atherosclerosis? So, C, pneumonia causes atherosclerosis as well. So, this completes our chapter. Next, we'll be starting with tuberculosis. Meanwhile, like, share, subscribe. Thanks for watching.